Hello and welcome back everyone. So continuing our discussion about the airway management, and after we talked about the bedside assessment of the airway and the modalities of airway management, now we are going to talk about the positive pressure ventilation. So the non-invasive positive pressure ventilation involves the delivery of oxygen into the lungs via positive pressure through a face mask without the need for endotracheal intubation. So the whole idea of the positive pressure ventilation is increasing the outside pressure to make it easier for the air to enter the lungs. So it is achieved with a sealed face mask, like you can see here, and a ventilator, like in this case, or a standalone device. So this device is pumping the air through higher pressures to make it easier for it to go through the lungs, and this would lead to less respiratory muscle use, means the patient would be in less respiratory distress, and this would also lead to the alveoli staying open and preventing them from collapsing in cases such as chronic obstructive pulmonary disease and cardiogenic pulmonary edema. So non-invasive means using face masks, and invasive means endotracheal tube insertion or surgical airway. Now the positive pressure ventilation is delivered via a full face mask using either continuous positive airway pressure, which is CPAP, or bi-level positive airway pressure, which is the BPAP, using a ventilator or a standalone reusable device. This picture showing the ventilator here, and this picture showing the reusable device. Now the continuous positive airway pressure ventilation provides the same amount of pressure support during inspiration and expiration, and the pressure delivered from 5 to 20 millimeters mercury. So you start with 5 millimeters mercury and you titrate up according to patient response. On the other hand, we have the bi-level positive airway pressure ventilation. Now the CPAP is the older technology and the BiPAP is the more newer technology, and it provides different values for inspiration and expiration pressures. So you can choose a pressure for inspiration and you can choose a pressure for expiration. The inspiratory pressure is called IPAP and the expiratory pressure is called EPAP. So it allows increasing the inspiratory pressures up to 15 millimeters mercury without overwhelming the patient with expiratory resistance. So you can increase the inspiratory pressures without increasing the expiratory pressures. And this would make it easy for the patient to exhale air. So the expiratory pressures remain from around 5 to 10 millimeters mercury, and the inspiratory pressures can go up to 15. And there are no studies showing a significant advantage to one system over another, although theoretically the BiPAP sounds better. Now let's talk a little bit about the normal physiology of respiration. So breathing is a negative pressure process, and the negative pressure comes from expansion of the chest, which is increasing the volume of the chest due to elevation of the ribs. So the ribs elevate and the diaphragm relaxes to increase the volume and lead to negative pressure inside the lungs. And the negative pressure would suck the air out into the patient lungs. Now in expiration, the opposite occurs. So the ribs depresses and the diaphragm contracts upward, which lead to positive pressure inside the chest, pushing the air out into the outside environment. And the non-invasive positive pressure ventilation work by increasing the outside pressure which help the air enters the lungs easier. Now, the non-invasive positive pressure ventilation is used in chronic obstructive pulmonary disease and in cardiogenic pulmonary edema mostly, and in COPD there is air trapping inside the lungs due to emphysema and bronchitis. So the air trapped inside the lungs would lead to increasing the pressure inside the lungs, and this would make it hard for the patient to inspirate air because there is already a positive pressure inside the chest. So the patient respiratory muscles would work harder to get the air in. So they have to contract more to decrease the pressures leading to the air coming in. And the positive pressure ventilation would help that by increasing the outside pressures, and this would lead to the breathing being easier. So we already have higher pressures inside the chest. So in the positive pressure ventilation, we have higher pressures from outside. This would lead to the higher pressures from outside getting the air in against the higher pressures from the chest. Now the same applies to the alveoli that are filled with water in pulmonary edema. Now let's talk about the indications. So the positive pressure ventilation is indicated in respiratory failure, which is hypoxia and or hypercapnia. And that is when the lungs are not working well and they need help. And according to the American Thoracic Society and the European Respiratory Journal guidelines, that the non-invasive positive pressure ventilation is strongly recommended in the settings of respiratory failure due to acute exacerbation of chronic obstructive pulmonary disease, where the pH is less than 7.35. This means acidosis due to higher levels of carbon dioxide in the blood, means the patient in respiratory failure having hypercapnia, which means they can't exhale the carbon dioxide. Now the NPPV is also strongly recommended in the cardiogenic pulmonary edema. Now the NPPV is also effective but to lesser degree in the post-operative acute respiratory failure, and the early NPPV in immunocompromised patient with acute respiratory failure, and it is also effective in palliation to dyspneic patients in terminal cancer and other terminal conditions, because remember, the NPPV lead to less respiratory muscle use, means the patient would be in less respiratory distress, and this would help in patients with terminal cancer because they don't have much muscle mass inside, and in patients with chest trauma with acute respiratory failure, and also in chronic obstructive pulmonary disease patients with hypercapnia, and in obesity hypoventilation syndrome, and in obstructive sleep apnea, because remember, in obstructive sleep apnea there are soft tissues blocking the airway, so when there's positive pressure coming from outside, this would help opening the airway through these soft tissues. Same applies in obesity because you have much bigger soft tissues and they would be hard to get the air in through them. So the positive pressure ventilation would push the air in. And it is also effective in respiratory failure due to neuromuscular disease and restrictive thoracic disorders. Now the NPPV is also used for pre-oxygenation prior to intubation in any medical condition, or as an alternative to invasive airway management in some cases, such as in patients with do not resuscitate or do not intubate status. The NPPV is not that effective for pneumonia. It may even delay mechanical ventilation, leading to worse outcomes. And it is used only in case of shortages of invasive ventilation equipment and facilities, such what happened during COVID-19. so it would be an alternative to invasive ventilation. Now let's talk about the device settings. So in CPAP, there is one pressure setting. We start from 5 millimeters mercury and titrate up according to response, and that is clinical improvement and vitals, and the max is 20 millimeters mercury. Now in BPAP, we have two pressure settings. We have the IPAP, which starts from 10, and the EPAP, which starts from 5. And the sum of both these pressures should be less than 20. Now pressures in NPPV above 20 millimeters mercury for both would lead to abdominal distension. So the air would go into the stomach and lead to distension. That is why we don't go above 20. Now let's talk about the device parts. So we have the mask, which is several types, including nose masks, nose, mouth masks, and helmets. We have the tubing, we have the oxygen supply, the power supply, and the humidifier. Now let's talk about the complications. So those include the mask discomfort and skin rash secondary to infection or hypersensitivity reactions, and they also include the nasal bridge ulcers, which are rare, and they include aerophagia and hypersalivation, and they include the ear and sinus pain and gastric insufflation. And the serious side effects with the positive pressure ventilation include pneumothorax and pneumocephalus and pneumomediastinum and aspiration and pneumonia. Now in patients with heart failure who are hypotensive, the positive pressure ventilation might aggravate the hypotension due to increased intrathoracic pressure and increased right ventricular afterload and decreased preload, because higher pressures inside the chest would make it hard for the blood to return to the heart, and patients with heart failure who are hypotensive would suffer. Now complications specific to the bi-level positive airway pressure ventilation include the patient ventilator dysynchrony, and this means failure to trigger the breathing cycle, leading to the inspiratory positive airway pressure applied during expiration and the expiratory pressure applied during inspiration. This would lead to inadequate gas exchange and unnecessary expiratory muscle use. For example, in chronic obstructive pulmonary disease, where patient is rapidly inhalating, this may not give the bi-level positive airway pressure ventilation adequate time to cycle from inspiration to expiration, and thus the patient is expiring against ventilator effort to deliver inspiratory pressure, leading to respiratory distress. Now also failure to trigger the cycle is seen in neuromuscular diseases such as the amyotrophic lateral sclerosis, where the patient cannot generate enough negative pressure during inspiration to trigger assisted breath. Now let's talk about the contraindications. So the NPPV is contraindicated in patients with a lot of secretions requiring frequent suckers, and it is also contraindicated in vomiting. That is because it requires a sealed mask, and it is contraindicated in an agitated patient because it requires a cooperative patient who can listen to commands and apply them. And it is contraindicated in comatose and sedated patients because these patients cannot follow commands, and it is contraindicated in hypotensive patients because it would aggravate the hypotension. Finally, let's talk about the prognosis. So the NPPV has shown to reduce the intubation in COPD and cardiogenic pulmonary edema cases, and it is shown to reduce the need for re-intubation in hypercapnic respiratory failure following extubation. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support more, you can by joining the channel via the join button below or through the link in the description of this video.